Welcome back to ShockDoc Medical. Before we dive into today's topic, a quick word. If you're experiencing joint pain or any health concerns and would like personalized medical advice, reach out to me directly on my Telegram, my private doctor. You'll find the link in the description below for private one-on-one consultations. Now let's get started. Today, we're discussing septic arthritis. It's an emergency in the world of acute joint pain because it can destroy a joint within days if not diagnosed and treated promptly. In adults, septic arthritis most commonly affects the knee, while in children, it usually targets the hip. Patients over 65 years of age are at higher risk, so always maintain a high index of suspicion in older adults. When we consider the usual pathogens, remember that in patients under 35 years old, Neisseria gonorrhoeae is the most common cause. In patients aged 35 and older, it's most often Staphylococcus aureus. Clinically, patients present with fever and a joint that is warm, red, swollen, and very painful. You'll see that both active and passive ranges of motion are significantly decreased. In cases of gonococcal arthritis, there may be no urethritis or vaginitis. Instead, patients can have a prodrome of migratory arthritis, tenosynovitis, and a characteristic pustular rash on the hands and feet. And if two or more joints are involved, always consider the possibility of infective endocarditis. However, not every red, painful joint is septic arthritis. Your differential diagnosis should include toxic or transient synovitis, abscess or cellulitis around the joint, rheumatologic disorders such as vasculitis, rheumatoid arthritis, or systemic lupus erythematosus, reactive arthritis often following streptococcal infection, osteomyelitis, crystal-induced arthritis including gout or pseudo-gout, trauma such as fractures or ligament injuries, malignancy, and seronegative spondyloarthropathies. To confirm the diagnosis, arthrocentesis with synovial fluid analysis is essential. Here's what you need to know. In normal synovial fluid, clarity is transparent, color is clear. White blood cell count is less than 200 cells per microliter. Polymorphonuclear cells make up fewer than 25%. Cultures are negative. Lactate is under 5.6 millimoles per liter. LDH is below 250 units per liter, and no crystals are present. In non-inflammatory fluid, clarity remains transparent. Color turns yellow. White blood cell count ranges from 200 to 2,000. Polymorphonuclear percentage stays under 25%. Cultures remain negative. Lactate stays under 5.6. LDH remains under 250, and no crystals are present. In inflammatory fluid, clarity becomes cloudy, and color remains yellow. White blood cell count rises from 200 to 50,000. Polymorphonuclear cells exceed 50%. Cultures are still negative. Lactate stays below 5.6. LDH stays under 250, and crystals may be present. In septic arthritis, clarity is cloudy, color is yellow, white blood cell count exceeds 25,000 in adults. Polymorphonuclear cells exceed 90%. More than half of cultures are positive. Lactate is above 5.6, LDH is over 250, and no crystals are found. Keep in mind that a synovial white blood cell count under 50,000 makes septic arthritis unlikely, but it does not rule it out entirely. Always pair your fluid analysis with blood cultures, a complete blood count, an erythrocyte sedimentation rate, which has about 94% sensitivity, and a C-reactive protein level with roughly 92% sensitivity. If you suspect gonorrhea, obtain cultures from urethral, cervical, pharyngeal, and rectal sites as appropriate. Use imaging studies to exclude trauma, osteomyelitis, and other conditions. And in immunocompromised patients, broaden your differential to include mycobacterial and fungal organisms. Once the diagnosis is confirmed, prompt antibiotic therapy is critical. For gonococcal infections, start ceftriaxone 1 gram IV daily. After 3 days of inpatient therapy, if the patient is stable, you can switch to cefixime 400 milligrams by mouth twice daily as an outpatient. For non-gonococcal infections, combine vancomycin at 15 to 20 milligrams per kilogram IV twice daily with one of the following: ceftriaxone 2 grams IV daily, cefepime 2 grams IV 3 times daily, ceftazidime 2 grams IV 3 times daily, or ciprofloxacin 400 milligrams IV 3 times daily. In pediatric patients, use ceftriaxone 1 gram IV daily. Sickle cell patients require coverage for both Salmonella and Staphylococcus species. Use vancomycin 20 milligrams per kilogram IV twice daily, plus either ciprofloxacin 400 milligrams IV 3 times daily or imipenem cilastatin 1 gram IV 3 times daily. Antibiotics alone may not be enough. Involve orthopedics early for possible surgical joint irrigation and debridement. Although serial aspirations can be performed, it's unclear whether they are superior to open surgery. Finally, disposition. Admit all patients with suspected septic arthritis. Close monitoring and collaboration among medicine, orthopedics, and infectious disease teams give your patient the best chance at a full recovery. Don't forget to like, subscribe, and click the link in the description to consult me one-on-one on Telegram @myprivatedoctor.